How effective are antidepressants? In this video tip, I will answer this question, one of the most frequent I have been asked over my 35 years in practice as a psychiatrist, working with people with various combinations of complex chronic diseases and mental health symptoms. The questions are, do antidepressants work? If so, which are the most effective? And given that we, with complex chronic diseases, tend to be more sensitive to side effects, which are the best tolerated? I'm going to answer this question in two ways. First, by summarizing two landmark meta analyses by Cipriani and colleagues, so the research evidence. And second, by sharing my personal clinical experience having worked with thousands of patients. Keep listening if you want to hear which antidepressants are the most effective, which are the best tolerated, and my personal prescribing practice. An important caution, this video tip is about using antidepressants for depression, for mental health symptoms. It is not about using them for fatigue, ME, or long COVID. The research is very clear that antidepressants do not benefit any of the core symptoms of ME and should not be used for this purpose. In the first edition of my manual, Let Your Light Shine Through, I address the question of antidepressant effectiveness by citing the first of the two meta analyses published in 2009. Cipriani and colleagues from Oxford University found that the most effective drugs at that time, based on head to head comparisons, were, drumroll please, mirtazapine, trade name Remeron, escitalopram, trade name Cipralex, Venlavaxine, trade name Effexor, and sertraline, trade name Zoloft. I prescribed all of these drugs over the years. Of the group, I found that mirtazapine was perhaps the most limited and the least used by myself. This is because it's very sedating and many patients couldn't tolerate that. And I also found it had a tendency to wear off over time. The best tolerated antidepressants in this first review were bupropion, trade name Wellbutrin, citalopram, trade name Celexa, escitalopram, trade name Cipralex, and sertraline, trade name Zoloft. You'll notice that escitalopram and sertraline appear on both lists. This means that compared to other drugs, they appear to be both effective and well tolerated. It was this finding about that time that launched escitalopram into prominence, especially among family doctor prescribers. As new antidepressants have been released, I, of course, would get asked about them. And luckily, Cipriani and colleagues published an update in 2018. I discuss it in more depth in the second edition of my manual, Let Your Light Shine Through. So, in this second meta analysis, which was enormous, it included 522 RCTs, randomized control trials, with over 116,000 participants, and it compared the 21 then available antidepressants, both with placebo and with each other. Effectiveness was defined as a 50% or greater reduction in symptoms, and acceptability was based on dropout rates. So, generally, if people quit taking a drug, it's either because of side effects or because it's not working. So, to answer the questions, do antidepressants work? There have been thousands of randomized trials of antidepressants, and most show a moderate superiority over placebo. To put a number to that, they are about 42% more effective than placebo in lessening the symptoms of major depressive disorder. The numbers are different if you start looking at other conditions. They're 70% more effective than placebo at reducing the risk of relapse, especially if continued on a daily basis for up to 3 years. Now, in the second study, there are 5 drugs that make it to the best of list, meaning they're both effective and acceptable. Three of them are repeats from the first list. These are escitalopram, sertraline, and mirtazapine. There are two newcomers, agomelatine. This goes by the difficult to pronounce names valdoxin and Vimanax, and vortioxetine, which goes by the trade name Trintellix and Brintellix. For reasons that I don't understand, drug companies tend to have more than one trade name for drugs that are available in more than one country. Now, agomelatine, in my assessment, is a case of failure to launch. It's an antidepressant which looked good on paper and made it on this best of list, but it just never panned out in clinical practice. It was never available in Canada. Health Canada never gave it the seal of approval, so I don't have any personal experience with it. But I've read follow-up papers suggesting that it's just not that effective and it's not widely used. Vortioxetine is a different story. It's being claimed that vortioxetine improves the cognitive function in people with depression, and that led people in the complex chronic disease community to wonder, would it help us as well? It is available in Canada. I had several patients try it towards the end of my time in practice, and many of them did feel that there was a subtle improvement in their cognition. Now, there's another list of drugs that are deemed to be highly effective but not very well tolerated. The first of these is paroxetine or Paxil. I agree with that assessment. When people use paroxetine, it acts quickly and it's often very effective. But when they try to go off it, oh my goodness, something occurs called discontinuation syndrome, and it can be extremely difficult, causing people a lot of grief and a very extended weaning process. When I first noticed that, probably 15, 20 years ago, I stopped prescribing paroxetine at all because it's just not worth it. The second drug that has maybe this mixed assessment is amitriptyline. The original trade name was Elavil. Now, over the years, contrary to what Cipriani reports, I found Elavil or amitriptyline very effective and often surprisingly well tolerated in people with fibromyalgia. In this community, it's commonly used for multiple purposes, including as a sleep aid because of the antihistamine properties, for pain because it's a central desensitizer, and for low mood. It is true that when amitriptyline is used at full dose, that's 2 to 300 milligrams per day. Yes, you heard me correctly. It's not very tolerable or very pleasant. But when it's used at low doses, somewhere between 5, 25, or even as high as 50 milligrams, which is typical in fibromyalgia, it's typically well tolerated. And even at that low dose, has a surprising antidepressant effect. Now, for some time, Venlavaxine was my favorite antidepressant. One reason was because it was effective and well tolerated, but also because it comes in a whole bunch of different sizes. This means that for me as a psychiatrist who followed my patients closely, I could titrate to the best dose to optimize benefits and side effects. Now, that same reason that I liked venlafaxine makes it more difficult for primary care prescribers who don't have as much experience with the drug or as much time with their patients. So many of them put it in the too hard category and prefer drugs that only have one or two dosing options. A couple really important notes about antidepressants. Many people with depression feel suicidal. They have anhedonia. Life isn't pleasurable and they don't feel that it's worth living anymore. Antidepressants, surprisingly enough, do not appear to reduce suicide rates, and especially in people under the age of 25, they may actually increase the risk of suicide in the first few months of use. So if you have depression and suicidal thoughts, please only try antidepressants in close collaboration with a skilled provider. Another important note about antidepressants is that if you read the research, you might come away thinking they work great and they put people into quote unquote remission, meaning they feel fine. Unfortunately, this isn't the case. Research shows that most people deemed to be or judged to be in remission actually still have three or more symptoms, things like sleep disturbance, weight changes, low energy, or brain fog. So, what are my views on antidepressants in the context of complex chronic diseases? First of all, despite all of the cautionary, discouraging, and even alarmist information you might hear about antidepressants, in my experience, many people with major depressive disorder benefit from them, and in some cases, significantly so. This remains true whether underlying the depression is a complex chronic disease like ME, long COVID, FM, or other things like POTS, MCAS, etc. So even though the research studies on a particular treatment may be encouraging, I have learned that the people I work with are ordinary humans, and we are not the same as carefully selected study participants. We are messy. We have complicated lives. We live in uncontrolled families and environments. We have a host of additional health concerns. We may have ongoing infections, toxic exposures, sensitivities, and really difficult life circumstances. For this reason, just because a drug looks good in a study doesn't mean it's going to work for us or for you in particular. If a drug or any other treatment doesn't work, it's not your fault. It means that your unique constellation of symptoms and underlying causes have not responded to the treatment, even though it may have helped countless others. The bottom line is that mental health treatment is complicated and nuanced. There are no blanket solutions. Antidepressants have utility when they're carefully selected, properly used, properly dosed, and the side effects are tolerable, but they're not miracles. Some final thoughts: do your due diligence. Be cautious when trying any new treatment. Understand potential side effects and ask thoughtful questions. Ask all your questions. Most importantly, avoid rushing into decisions unless the situation is urgent. Thank you for listening to this recording. If you are a visual learner or know someone who is, check out my blog page for the sister blog to this recording, or read my new second edition manual, Let Your Light Shine Through, for more on how to differentiate mental health symptoms from those of ME/CFS and fibromyalgia, how to manage various forms of depression and anxiety that arise in people with complex chronic health conditions, and much more. If topics like this are of interest to you, consider joining Live with Dr. Stein. I meet with you every other Thursday, and I teach about cutting edge research and accessible strategies to improve health and quality of life. Please support long form video content by following me on YouTube and commenting what topics you would be interested in learning more about. Until next time, I'm Dr. Ellie Stein.